Hello, everybody. My name is Lourdes Quintana, and I am the Charge Syndrome Foundation's Outreach and Engagement Manager. Thank you so much for joining us today at our presentation. We are very excited to share with you this very special presentation from the team at Rady's Center for Charge Syndrome. And before we do that, we're going to go over some accessibility things that we want to share with you. First of all, closed captioning is enabled. So if you would like to turn it on, you are able to do so in the control panel under your screen. We're also going to be providing ASL interpretation. If you like, you could highlight your interpreters so you're going to be able to see them. And we are going to have Spanish interpretation as well. And the Spanish interpreters are going to share more information about how to access this now.
Hello, everyone. Good evening, good afternoon. My name is Jancy. I'll be one of your Spanish language interpreters together with my co-interpreter, Kenton. Can everyone hear me okay? Yeah.
Yes.
We ask that everyone please speak one person at a time as we can only interpret one voice. Please announce your name when you speak slowly, and always be mindful of the speed at which you speak, especially when reading text directly to facilitate simultaneous interpretation. Once the interpretation feature has been turned on, we ask that everyone please select either the English or the Spanish channel. Everyone must select a channel, English speakers included. If you're fully bilingual, please select your channel of preference as well. To access interpretation, if on a computer, select the small globe icon at the bottom of the screen, or if on a mobile device, select the three dots that say More, select Language or Interpretation, choose the channel of your language of preference, and click Done. If you have any issues with interpretation, please contact either of the Spanish interpreters so that we can help. Thank you for your commitment to language justice, for enabling this multilingual space, and thank you for your attention. Now I'll be switching to Spanish before we begin. Buenas tardes, soy Yancy. Habrá interpretación al español durante esta llamada. Seré su intérprete de español e inglés junto a mi colega Kenton. Le pedimos que hable una sola persona a la vez, ya que solo podemos interpretar una voz. Por favor, anuncie su nombre al hablar, hable despacio y tenga siempre en cuenta la velocidad a la que habla, especialmente cuando lea texto directamente para facilitar la interpretación simultánea. Una vez la función de interpretación sea activada, le pedimos a todos que seleccionen un canal, ya sea el de inglés o el español. Todo el mundo debe seleccionar un canal. Las personas que sean completamente bilingües deben también elegir el canal de su preferencia. Para acceder a la interpretación, si está en una computadora, seleccione el icono del globo pequeño que aparecerá en la parte de abajo de la pantalla, o si está en un dispositivo móvil, seleccione los tres puntos que dicen más, seleccione idioma o interpretación, elija el canal de su idioma de preferencia y haga clic en Listo. Si tiene algún problema con la interpretación, comuníquese con cualquiera de los intérpretes para que podamos ayudarle. Gracias por su compromiso con la justicia del lenguaje y que este espacio sea uno multilingüe, y gracias por su atención. You may now enable interpretation and begin. Thank you.
Thank you. There you go. We're now starting with the interpretation rooms. Again, Ask the Expert is a monthly webinar that we offer with the Short Syndrome Foundation. And again, it is my pleasure to welcome our team from Rady's Children's. And first, we're going to have Dr. Brigger that's going to be sharing with you some very important information about secretions and how to manage them. So without further ado, I'll give you Dr. Brigger.
Excellent. Well, thank you so much. We're really excited to be able to come join you. I will try not to speak fast, although this is something that we're very excited about. And so we will try to keep things in line with the interpretation. Let me get my screen shared. And so basically what we're really excited to do is to spend a little bit of time to talk about this particularly difficult problem being in terms of secretion management. And as you guys all know very, very well, Secretion management is such a big issue in children with Charge syndrome, and it's really just as a privilege for us to be able to take care of these kids together with you and with the various families that we get to join. So it's going to be myself. I'm an otolaryngologist, and I'm going to be joined by Kim Morris, who is a speech and feeding therapist, and Aparna Rao, a pulmonologist. And we're all going to take a little bit of time to talk about sort of our different perspectives as we work our way through and kind of go through this journey, because at the end of the day, secretion management really is a journey, and and each individual child goes through and each individual family goes through something different along the way. And so we're hoping we can find some common themes and be able to open it up for questions, be able to work our way through. So with that being said, let's get rolling. Just want to put a little plug for our Center for Charge Syndrome. This has been a journey for us as well. And over the past, as we have really come, with the founding by several different members of our team and really being spearheaded by Dr. Daniela Carvalho, it's been really a privilege to really build the center and be able to provide the care for so many children, particularly based off the West Coast here. And so with that, I do want to also just to take a moment just to introduce sort of what we do. So we're the Center for Pediatric Aerodigestive Disorders and Airway Surgery. And really where our focus comes in is on the swallowing and breathing side of kids with Charge syndrome. As you guys well know, about 90% of children with Charge syndrome have some degree of issues that fall into our purview. So when kids come to evaluation at our center, the vast majority come through the Aerodigestive program. And so with that, I'm going to go ahead and pass the baton over to Dr. Rao, and she's going to talk to you a little about how we can all work together using a team model towards taking care of children and their secretions.
Well, thank you very much. I'm very excited to be here today. My name is Aparna Rao. I'm a pediatric pulmonologist. I'm part of the Aerodigestive team. We wanted to approach this topic together because nothing happens in isolation. So if there is airway obstruction, the lung can be affected. If there is swallow dysfunction, lung can be affected. And that is why we work together as an integrated practice unit, where we are just the three of us that are representing Aerodigestive team, but we also have gastroenterologists, occupational therapists, nutritionists, pediatric surgeons, and many other nursing. All of us work together so that we improve, aerodigestive care in children with Charge syndrome. When we work together and we take care of these children together along with families, I think, like Dr. Brigger mentioned, this comes with the best outcomes because all of us are thinking from one perspective, but we all sit down in a clinic and talk together. The discussion can change in any direction, and then we make a very comprehensive plan. Can we go to the next slide, please? I think this is a concept which is very important, that just like the lungs don't work in isolation, as clinical experts, neither do we. We all come together and the team works together so that we all help with swallowing. That then impacts what the respiratory health of a child can look like if we, sit together and make plans together. Okay, can we go to the next slide? So this is my perspective as a pulmonologist. And when I'm seeing a child with Charge syndrome, I want all children to have the best breathing pattern, the best swallow, and they continue to thrive and they continue to have the best quality of life. Next slide, please. So lung, in pulmonology, we often say that lung is often not the primary problem in children with secretion management issue or with reflux or with aspiration. It is usually because it is the end organ that is impacted because of misalignment of systems, whether it's gut impacting the lung, whether it's swallow impacting the lung, and whether it is the heart that impacts the lung. So often we find that it is not about the lung being the primary organ. So we often focus on improving our lung strategies. And as we work together and we work with Kim from a feeding perspective, Dr. Brigger, we see that it impacts the way children's respiratory health is overall. So I feel like this concept of working together as a team along with families is crucial to the best outcomes of children with Charge syndrome. Next, please. So the problem is not that there is too much saliva. It's the swallowing mechanism that can sometimes be impacted, or that is impacted because maybe there are cranial nerves which are different, or the facial muscles that are not the same. And we see that these children will have obvious drooling where you can see saliva coming out of the mouth, or you can hear the sounds at the back of their throat. Often families come and tell us that their lungs sound great. It is all sitting up in the throat. And often that is because the swallow is impacted and the child is not able to take a nice swallow, or the cough receptors have to see a lot of saliva before they stimulate that cough. And that results in some of the secretions going down the food pipe, but some can then impact the windpipe. And once they see saliva or food, that results in more mucus production. So ultimately, that will impact their respiratory health. Often the gut is also contributing to this. If you have bad reflux, or if the gut is not as rhythmic, that means the peristalsis is such that it's not moving the food down or the saliva down, we call it gut dysmotility, and that will also impact the way the lungs or the respiratory health will behave. So again, the problem is not too much saliva, it's how the child is handling the saliva that impacts the pulmonary health. Next slide, please. So here the lung is seeing a multi-system burden. When I talk about a multi-system burden, like I said, the lung does not work in isolation. It works with alignment of systems. And that is why as experts, we align ourselves. So from an airway perspective, children can have small nares. They can sometimes have what we call as malacia, whether it's laryngomalacia, tracheomalacia. So often children with Charge syndrome can have congenital heart disease. That also impacts the lungs. Like I mentioned, a lot of gut dysmotility issues, or the tracheoesophageal fistula that impacts. They may have swallow issues. Often children may have some developmental delays, seizure disorders, obstructive sleep apnea. All of it then impacts the lung. And the biggest impact is seen when they are infants or early childhood. And there are two reasons for it. One is that this is the time where we are programmed to get our respiratory illness. And second is this is also the time where we are learning new skills. We learn skills to talk, walk, and everything else. Charge syndrome children have their own milestones. And when they're babies or they're toddlers, that's the time they see the maximum impact of respiratory illnesses. And this is why we have many, many challenges. And the good part of it is that as children grow older, a lot of them will show improvement with all of us working together, aligning as these problems into complex problem into something more manageable. So let's talk about what can we do to decrease the volume of saliva, or how do we get our children with Charge syndrome to handle a certain load of saliva. Kim will talk a lot about what are the strategies, but from my perspective, medical management, how do I bring the secretions down? I use medications. You guys, I'm 100% sure you all know about Robinol or glycopyrrolate. There are scopolamine patches, there are atropine drops that we use. All of this is with the goal of decreasing the volume of saliva so that as a team we can work on their swallow function. So all the saliva then goes into the esophagus, very little comes into the airway, and very little then escapes into the lung. Now there is a balance. There is no perfect medication. every child needs a personalized plan of management. Some families will tell you that these medications make the secretions too thick, they dry out the mouth, and the child is agitated, constipated, their gut doesn't function very well. Then that's not the medication for the child. Then we got to think of other strategies. So that will, Dr. Brigger will touch on it. He will talk about what is the surgical approach to it. But the concept here is that we always think of medical management. We always think of what is best for the child and for the family and how to keep the side effect of a medication lowest. And some of your questions.
Doctor, I'm so sorry to interrupt you.
Yes.
It looks like we have an issue with our interpretation rooms.
Oh.
The Spanish is in the English and the English is in the Spanish. So give us 1 minute because
Okay.
we're learning more than what we bargained for today.
Okay. Okay.
So
It's all good.
give
Okay.
us a
Pause.
second. Let's see. All right, interpreters, what else do we have to do?
So can I start?
Give us 1 more minute. Let me
Sure.
wait for
Sure.
confirmation from the interpreters. It looks like we're good now.
Ya que estamos
So,
bien ahora, entonces ya podemos proceder.
okay, we could go in.
Okay.
Thank you.
So should I summarize or can I keep going from where I am? What do you think?
You could keep going because we don't know
Okay.
exactly where we lost the change. So,
Okay.
thank
Okay.
you.
So I was talking about the management of too much saliva and the medications we use. And I think there is no perfect medication. For everything has to be personalized based on how the child handles the medication, because the goal here is to keep the volume down without thickening the secretions too much and also avoiding the side effect of medications that we use. So that is the goal of these medications. And this is why when we see you, we go through our medications, we talk about oropharyngeal hygiene. Can we go to the next slide? Now, we have medications that can improve swallow by decreasing the content or the volume of saliva, but there are medications that can also worsen swallow or increase secretions. And some of these medications are like sedating medications, because when you are sedated, your swallow is not going to be optimal, like clonazepam or diazepam, or medications like baclofen or gabapentin that may decrease your muscle tone and again, or coordination again, then your swallow muscles will see weakness and they will not do a very good job. Meds like Omfi actually increase the volume of secretions. If you are on morphine or oxycodone, again, your respiratory is suppressed, your swallow is not optimal. And seizure medications and also the medications that we use to decrease the volume of saliva can sometimes affect the gut, and some of the neuropsychiatric medications as well. So it is extremely important that when you're seeing a team, we go through the medications and we look at the impact of medications. And the families are the most important people to inform the medical team whether they think that these medications are impacting their swallow or making their secretions too thick or their mouth too dry. All of it comes together as you see us in clinic visits. Now, we talked about secretions. We talked about, how the secretions can impact and escape into the airway. But then how do we get rid of these secretions? And that is very important. This is also called as airway clearance strategies. But a secretion exit strategy is what you have to think of. because what the goal of the pulmonary care is, one is to loosen this mucus, because we are using medications to kind of decrease the volume of the saliva, but in the lungs, it can sometimes become thicker and children can cough more. So then we can hydrate, because now, like I said, we have to balance how much of it is that we want to control the saliva, improve swallow, versus how can we accept a little bit of thickened mucus, but then hydrate it with saline or hypertonic saline to loosen it, and then to bring it out by various therapies like chest clapping. I'm sure some of children are on vest therapy, where we use a certain frequency of to break down the mucus and to move the mucus from the small airway to the big pipes, so that the child can cough it out, or it can be removed by various other mechanisms like cough assist. So it is very important that we think of loosening the mucus and moving the mucus centrally. The other ways to do it is exercise, exercise, exercise. The more your child moves, whether it's using a stander, moving from side to side, walking, crawling, creeping, encourage it, because that is how things move in the lungs. Movement is key for the lungs and for the secretions to move to an area where there are cough receptors and we cough it out. Humidity can be provided by nebulized saline, hypertonic saline, and sometimes just in the environment. Like, if you're in a humid environment, it's very good for your lungs. If you're not, then you use other strategies. And mucolytics, like again, hypertonic saline is a mucolytic, but sometimes we can use pulmozyme, but we don't use it on extended periods. But acutely, pulmozyme has also helped children to loosen mucus. I'm sure you guys also, children are getting physical therapy and different mobility equipments. Go for it. The more we move, the better it is for the secretions to move as well. So it would be very important for children to create these kind of exit strategy for mucus and decrease the episodes of acute or chronic tracheobronchitis. That is what sits in the airway. Mucus sitting in the airway is bronchitis. That is what it is. Can we go to the next slide? And finally, getting the secretion out is best by, a strong cough. But if your cough is not as strong, we have what we call as cough assist devices. This is also useful in children who sometimes need tracheostomies to help with their breathing, or to help with the, tremendous amount of secretions. So we establish a second airway so that, secretions don't sit and they don't choke on it. So it could be with the cough assist or with suction strategies. Now there is when you have all these episodes of acute or chronic bronchitis and infections from the community, often we hear a chronic wet cough, and it could be related to infection or it could be related to swallow dysfunction. Sometimes we have to use antibiotics. Acutely, we could use oral or IV, but sometimes in children with tracheostomies who have pseudomonas, which has become very, very challenging, we often use inhaled tobramycin to kind of keep the bacterial load such that we don't have a lot of green or yellow secretions. And often the strategy is used like we would use in children say with cystic fibrosis, where we use just to keep their respiratory health as good as possible. We also use anti-inflammatory. Azithromycin is an antibiotic, but it has some phenomenal anti-inflammatory effect, which again helps reduce the inflammation, the biofilms that are formed when you have tracheostomy sitting in your airway. So all these different medications kind of help with giving a more overall better, holistic, good health in spite of the challenges that the children, families, and the physicians are trying to overcome. Now, what are we most worried about? So when you hear wet cough, we often get worried, oh, what do we do about the wet cough? But if the wet cough is not associated with high fevers or it's not associated with any other changes in oxygen, it is something which we have to treat by other strategies as well that Kim will talk next more about, and also with what I discussed. But then if this progresses to what we call as multiple episodes of needing oral antibiotics, or where we reach a situation where we are constantly in and out of hospital getting IV antibiotics, then we are in a state where we are thinking of how do we help with the chronic suppurative lung disease. And again, the same concept, teams sitting together, looking at other areas that can be improved so that the respiratory health can be better controlled. And finally, what we are looking for is known as bronchiectasis, when there are little spaces in the interior of the lung that can harbor bacteria all the time. I call just that the lung is like apartment complex. The real estate just went up with a lot of little areas where more and more bacteria can sit, and that is what is called as bronchiectasis. And that can happen in children, but it is not as linear as what I have shown. It is, we don't know how much time it takes to develop bronchiectasis, and in children, bronchiectasis is also reversible. So the important concept here is that we need to get the respiratory health under control in a team environment with all of us looking at a problem from our perspective, and helping children with CHARD syndrome as much as possible. Can we go to the next slide, please? Finally, it is respiratory stability is not just about what is the oxygen saturation, how much oxygen does the child need. It is more about what is the child's respiratory health. How is the sleep quality? Is there a lot of problems sleeping? Did we reduce hospital admissions? Is he tolerating his feeds better because he's coughing less, or we have addressed the GI issues? How is the motor development? Is he developing as per their own growth chart, as per their own motor milestone? Are we getting them better? And also important is, what is the family life like? Are you guys exhausted? How can we help as a medical team? And I will let Kim take over and talk more about strategies from her perspective. And at the end of this talk, we will be ready for more questions.
Thanks, Dr. Rao. Hi, everyone. So we're going to shift perspectives a little bit into more from a functional standpoint, and how do we look at secretion management? And I have this picture of a child who is covering their mouth, could be sneezing, could be wiping drool. But when we think about functional secretion management, we want to think about not just what we see, but why are we seeing that? What is the function behind the saliva that's present? And then what do we do about that? Go to the next one. So when we think about functional secretion management in CHARD syndrome, we want to be thinking about what we actually see. So whether it's spilling of saliva from our mouth, whether we are hearing secretions in different areas that could be back in the throat, and then more importantly, why are they there? We can't figure out what to do about them, including from a medication standpoint, unless we understand why they're not moving. Just like when we eat, secretion should be building, and then you should be moving them back, swallowing, and then fully clearing. And every single child with CHARD syndrome is going to present differently of what their experience is and what their muscles and body systems are doing, what their brain tells their body to do. And we have to understand and work together with you, their parents, to understand, what do you see? Help us know your child the best so that we can then understand from a function standpoint, anatomy, physiology, and then come up with something that makes sense, is realistic to do in home and in therapy to make a difference. So I have this picture that it's a picture of when we put a scope in a patient's nose to look at their vocal cords. So if you look at the V that's right there, those are your vocal cords. So that's where you breathe in and out of. And when we go to swallow, we should be closing those off, and all of the secretion should be going down the back into the esophagus and into our belly. This is an image of some secretions, the white bubbly stuff that you see starting to enter through into the airway. We see we all know, we hear the words aspiration and concern of aspiration. Is my child aspirating? Like this pass fail, even when we talk about swallow studies, whether it's saliva or food, aspiration can happen. But it's more important to understand why, because if we don't understand why, we don't know what to do about it. And the reality of it is, it's usually not one reason why a child might aspirate. It's all of their body systems and how they work with each other, including with secretions, to help it happen less often. And if it is going to happen, how we help them clear and be healthy. So you can go to the next slide.
There you are.
Thank you. So what is secretion management? What are we talking about? We're talking about saliva. Dr. Rahul talked about mucus and clearance of mucus. Swallowing, how are we moving the saliva that's in our mouth, secretions down into our esophagus? And are we effectively doing that? Can the child do that? And if not, why? If it starts to go towards their airway, meaning aspiration, how do we help them have that happen less? Understanding why is the key to that. And then if it is, even when we've tried all of the things that we can do and we know, okay, it's really hard to manage those secretions. How do we improve airway protection? How can we improve our cough? And then also our oral health. Can we reduce the bacteria that's in our mouth so that when they have a lot of secretions and they're going down and a little bit slips towards the airway or a lot, there's less bacteria in that. You're going to have a healthier lung if you can have less bacteria. So making sure we understand how all of those systems work with each other. And the most important is communication of the child, parents, and our entire team, because you know your child the best. And as the child's able to let us know, we want to hear what they're experiencing, how they're feeling it. And that makes all the difference to know, are the things that we're suggesting working? And make those changes, not just one set recipe for secretion management. This is what you do. It will change for every single child. So why is secretion management difficult in CHARGE syndrome? So Dr. Rahul talked about this. There could be cranial nerve differences where their brain is telling their muscles to do something a little bit different or not as consistently as possible. There could be oral sensations that they don't notice that there are a lot of secretions to move them back. Before I keep going, on the right, where you see this is a swallow study where it's fluoroscopy, so like a live X-ray of a child that is drinking. So the liquid's going back. We want it to go down that back tube and not into their airway. It's the same thing as secretions, but whether it goes one way or the other, secretions or food, it's not just dependent on one factor. It's dependent on their environment, the information we're giving them, and the information their brain receives and tells their muscles to do. And it will not be one thing that we have to target or tell you to do or work on in therapy that's going to make all the difference, and not one medication. It's knowing the child the best to really make a difference. It could be low muscle tone, different swallowing differences, and airway coordination. So that's why sometimes we will be getting information from you to understand what's happening at home, what's happening with secretions. And even if the child is not eating tons by mouth, a swallow study can be really helpful information, or that scope that I had told you about, from a secretion management standpoint. Sometimes we want to know, why is it going that way? What are the muscles doing? What happens if we suction? And does that help them feel like, oh, I can swallow a little bit more because I feel safer to trust things? So that can be really helpful information to determine what therapy to do for secretions. So swallowing helps clear our secretions. We have to be able to move the secretions in our mouth move them back, swallow, have all of the muscles push those secretions down so there's not anything left over in the mouth and back in the throat. And oral movement matters. If you sit and you try to swallow with your mouth closed, or if you haven't been moving your mouth a lot, you sit and just try to swallow without moving. It's very, very difficult. And that happens with children with charge syndrome. When it goes down to this area, they feel it differently. They move their mouth or don't move their mouth, and they feel the difference of whether they're used to feeling secretions sit there and they might not respond, or if they start moving their mouth to push the secretions back and down, they might then realize, oh, I feel something back there. When they move their mouth, they feel the difference in their throat and can push it down more. So feeding also can increase swallowing frequency. So the more we swallow, the stronger our muscles are, and the more that we move food or liquid or secretions back, the stronger that our entire brain and body get to be able to know, oh, when I feel something back there, I should swallow. So if you think about when a child's born and all through infancy, we're talking about feeding, sucking, swallowing, breathing, sucking on a pacifier or not sucking on a pacifier. Things that we might see would be congestion during feeds, congestion or just kind of a wet sound when they're swallowing, fatigue. So secretion management might be okay, and a child is swallowing often, but then with meals or throughout the day, we might get more fatigued and let the secretion sit there more. And that's what we talk about when we say pooling. They just sit and hang out around the airway, like you saw in that picture of the scope. And there could be differences with their anatomy of their airway. And so it's important to, from the very beginning, to be understanding how we can help them feel good when they're swallowing, whether they're eating or not, work towards really trying to have them have an experience with swallowing food, liquid, so that their system becomes strong early on. When during the toddler and early childhood years, you might see more drooling. There's more activity where it's great that, like Dr. Rao was saying, they're starting to move their body more. That can help with airway clearance and mobility, but it also requires more demand to their brain to say, hey, keep swallowing often. It's common, all of us, we're focused on something and we're not thinking about what our body is doing. And that's the same thing with all children. So they might be starting to drool more often because they start to breathe through their mouth as they're starting to move around more. They could have oral aversion. That's a term that I don't love. It definitely exists. But when you think about secretion management, it's not just I have oral aversion or I don't. We want to be thinking, no matter what age the child is what is their oral experience and what might be oral aversive behaviors or things that we see, and how do we change that experience? It's not just you have it or you don't. If you have a lot of secretions and you're constantly choking on them, of course there's going to be oral aversive behaviors or kind of gagging and turning away. So when other things come towards your mouth, you pull off. But if we can help swallow more frequently, clear that down, use some strategies, maybe they can start trusting their system better. I might have some delayed chewing, which then could be, as you're working on those chewing, you build more secretions, and that's harder to manage. Like I said, we have more mouth breathing. And then sometimes with hypotonia, you can just have some reduced oral awareness. And how does that affect the function of your swallow? As we get into school age and adolescent years, the same things hold true. And it's not just one thing that you're going to see or not. It all depends on how that child has been building their systems over time, whether we're eating, whether we're not, what's our oral care, what's our cough clearance, and specifically, what is that child's muscles doing and how effectively? So you might hear a little bit of a wet voice where it's gurgling. We might need to help clear that. But why is that there? We don't care if it isn't bothering the child, their lungs are okay. We're not worried from a function standpoint. Who cares about a wet voice? But that can be a sign that the child is having trouble clearing their airway or moving secretion. So it's all about why and what's the function of their whole body, and all of us really understanding the child's experience and knowing the child the best. Social concerns, so we're starting to eat at school, be around friends, and drooling from a child's perspective might become more embarrassing. And how do we help them cope with that in a way that doesn't make them feel bad, and doing everything we can to help that happen less often if it's important to them. We can have fatigue with eating. And then again, oral hygiene is so important for reducing how much bacteria we have in our mouth, so that if we are having some go into our airway, that there's not a huge bacteria load that gets dumped at once and then can make our lungs sick. So really teaching children to have better oral hygiene themselves and empowering them to be able to use those strategies. Like we had talked about before, moving your mouth really matters. It's important to be understanding how that child is moving their mouth naturally. Even if we're not able to chew very well, the child is usually very smart at using compensatory strategies. And we say compensatory in they know, hey, this might be really hard, so I'm going to use my tongue in a different way to mash something up or to move those secretions back. And we don't want to just say that's wrong or oh, that's not the right way to chew. We want to use those skills that they've learned to do and to help shape that so that they can handle their secretions better. One of those things is you can go to the next slide. One of those aspects is jaw mobility. So how we open and close our mouth has a really big impact on how we can move our tongue and even how we feel those secretions when they sit in the back. If we just keep our mouth closed and we try to swallow like we talked about before, it's hard, it's very difficult. We want to move our mouth, control the saliva, and remind ourselves to swallow. But if you're not used to doing that, or you're protecting yourself because you're worried about aspirating or it feels uncomfortable, or just from muscle function, your jaw can get really tight. So just jaw mobility and paying attention to that early from the child opening and closing their mouth, or just range that the parent or therapist can do to be able to keep all the skills possible as they're learning new developmental skills. So that can help with chewing opportunities, can help with oral speech, and then preserving the range of motion. And then if there are jaw concerns, just like we talked about before, every child is different and has different anatomy. If we are going to really target that as a treatment where we notice that there's not a lot of movement of our jaw, we want to make sure that the physician also is involved so that we know what's happening with that TMJ joint. Always keeping in mind positioning. Positioning isn't just for eating. We often use positioning to help from an airway standpoint, to be breathing and swallowing a little bit better from infancy through adolescence, but that happens with secretion management too. And that can be different for every child. So if it's very difficult for a child to move orally their secretions back to swallow, sometimes a little bit of a reclined position can help, or an upright position to help the saliva come out a little bit more for a purpose so that they can control even more as they go to swallow and not feel so overloaded. There's lots of strategies, and it's not just a cookbook. It depends on the child, and that's where we all work together. Like we had talked about before, oral care is very important to reduce bacteria buildup and to avoid thick secretion. So making that part of our daily routine is important, especially when we're starting to explore oral feeding, regardless of how much, whether it's tastes, whether it's a full oral diet. before a child is eating, making sure that they do not have tons of secretions in their mouth that have been sitting there. And then we go and we put something in our mouth to swallow, and that pushes them all down. It's the same thing with when we do swallowing therapy or home exercises for swallowing, for secretion management. I'll often recommend that you suction beforehand, and there's different suctioning techniques that can be really helpful, not just finding the secretions and suctioning what you see, but sometimes instead of that big tip that you usually will have, a really teeny suction that you can create a path that will actually help pull secretions from back there and then give the child more confidence to swallow. But a lot of times we'll create a nice, healthy environment with oral care, even before doing swallowing therapy and encouraging jaw mobility and swallowing, even if we're not eating. So things that we think about through the day are hydration, making sure that our secretions are not super thick, the best that we can. Swallowing reminders, whether that's touch or us verbally saying that, and helping, making sure that we know that what are the best things to tell that child, not just a cookbook of here are all the ways to swallow, and I'm going to remind you and be a pain. Hey, you have more saliva, swallow again. What are things that aren't stressful to the child, but that help create improved function over time? There could be oral sensory activities where it just increases their awareness of their mouth, so they move it more often and then move secretions back. Scheduled oral care, and then rest breaks throughout the day where they can be not focusing on those strategies. So when are times that you would want to let your team know that you're noticing a change? You would, if you're seeing increased coughing with secretions, wet breathing, you're starting to see more illnesses, there's a change in feeding difficulty, or you see feeding difficulty that wasn't there before, or you see changes in secretions. And I can't imagine how frustrating it is as a parent to know that your child is struggling with secretions and you have tried lots of things and we're all problem solving together. And it's probably hard to notice if there is a change sometimes, if you're constantly seeing secretions there, or you could just get used to wet breathing. What I would say to that is really making sure that you work with your team, that we've done due diligence and really have tried to understand what your child's swallow function is. Where are the secretions coming in? Is there a reason why they come in from a certain way? Is there something we can do about that? What can we teach your child from all of the great things that they do to not just focus on the things that might be really hard for them or weak muscles, but how do we take the strengths? Maybe our oral movement is better. Maybe our tongue is doing really great things. Maybe it's our jaw. Maybe we're using like a pumping strategy that they came up with on their own that we might say, oh, that's not typical, but it works for them. How do we use all those things and really improve the strengths, which we know then can improve weakness or things that are not as easy for them? So it's not just about focusing on the things that are really difficult. So really not thinking of it as all this therapy every day and we need to focus on secretions and create a stressful environment. It's just understanding, what is that child experiencing? What are things that we can do to just help specifically them handle those secretions a little bit better, knowing that no matter what, when we do or any oral movement and what's a good way to be able to do that for that child, it will make a difference. And little supports together that are specific for the child to be able to implement throughout the day so that they have just a better life and experience with dealing with secretions and maybe some differences of airway clearance, and help them just feel the best that they can.
Great. Thank you, Kim.
Of course.
So we're going to change gears a little bit now. Now I've heard Dr. Rao kind of go through, and Aparna told us about sort of what to expect from the lung side and how we look at it. Kim's taken us through this journey looking at how we talk about it from a therapy standpoint and realizing that this is so much more of a bigger picture. And now I'm going to bring it in from more the surgical standpoint. So as a surgeon, let's be honest. I'm a surgeon. I look for things to do surgery on. And so no matter what, whenever you're seeing surgeons for this sort of thing, that's what we're thinking. But I think the important part to do is really step back and be able to understand sort of the balance between structure and function and how these things come together. So first of all, when we talk about just in terms of just the secretions in general, where do they come from? The majority of secretions actually come from three major glands. And these are located in your cheek and down in your chin. And what they are, there's a parotid gland, the submandibular gland, and the sublingual gland. And each of these kind of serves to help to be able to provide the saliva that we need and provide lubrication. There are also, throughout the mouth, there are many thousands of minor salivary glands that help just keep things moist. So it's important to realize that from an anatomic standpoint, therefore also from a surgical standpoint, that each one of these major glands does different things. So the parotid, which is the one in your cheek, that actually has nice thin secretions. So what this does is about 25% of the time when you're just kind of keeping your mouth at rest, when just kind of keeping things moist, they produce about 25% of the saliva. However, when you get hungry and you see food and your stimulation, they're the ones that really start pouring out. And that's so when your mouth starts to water when you see food, that's where it's coming from. Then you have the submandibular glands, which are down below the jaw. These are sort of these are the workhorse. These produce secretions that are they're kind of a combination of thin and thick. And so what they do is they help keep balanced lubrication. They keep our mouths moist. And then we have these little tiny sublingual glands. The reality is they don't do a whole lot. They produce but they produce the really thick part of the secretions. So it's important to realize that each of these glands produces different sort of types, different viscosities, which then becomes this very important when it comes to individual children as to whether their secretions are thin or thick. Are they coming anteriorly as drool? Or are they choking on them? And so it's part of some of the things that we have to think about. So that's sort of focusing on the saliva sort of standpoint, but we all know that secretions are not just located in the saliva. They're not just located in the lungs. They're in the whole tract all along. And so many children with Charge syndrome have difficulties in the nasal situation. And the nasal secretions tend to be very different in that they are a thick mucus that are designed to be able to trap any incoming bacteria and diseases. You take that with the anatomy of children with choanal atresia and the various different conditions that may be associated with charge. And what you do is you get a stasis of secretions. So this then becomes a problem of not just plumbing, but also sort of thickness and stasis of secretions where they sit and they just kind of collect, which then can become infected and lead to sinusitis. And so then you got two different sort of competing things going on, where you've got the salivary secretions and then you've got the nasal secretions, both of which can be problematic and both of which can be difficult and for different children. You take this all and you take a surgeon looking at it, and the surgeon's just trying to find a way to be able to just be a plumber. And at the end of the day, I'm a glorified plumber. I'm just trying to find ways to open up the pipes, make them bigger, make them smaller, turn things on and off. But it's not lost on me that when we really think about this, we do need to take this balance of structure, of function, so anatomy, physiology, but along with the environment and the coping mechanism of the individual child and the families. We know these secretions just in any child across the board, like these can be very difficult. And this can be a significant source of quality of life. And you take this sort of overlapping diagram per se, and then you throw a child with charge on that. And as you all know also well, and you guys have all taught us also well, is that you put charge syndrome into anything and it's like a box of chocolates. There's so many different ways and forms that it comes through. And so really it makes us just always remember that the charge kids, the chargers all have their own sort of sense of purpose and being, and they play their own tunes. And that's really where I think we try to come in and try to do our best to really understand and play the music with them. So certainly there's the physical ways of trying to deal with the secretions, and whether you're suctioning them, there's bulb suction, there's nose freezes. I know you guys have seen all these different things because there's all these different variations out there. And the reality is that it's going to be different. Some will work better for others. Some will work in different ways. It kind of depends on what the problem is. How thick are the secretions? How thin are the secretions? How much is it a nasal problem versus an oral problem? I think sometimes the role is it's not just suctioning, it's also being able to rinse. And that's where nasal irrigations and putting some medications in there can be helpful. But it becomes very tailored. And I think that's the one thing, if there's one thing I've learned by taking care of so many children with CHARGE syndrome, is that there really is no blanket surgery. There is no blanket therapy. As much as we want it to be, and as much as it may be in children who are unaffected, it's really just not the case. So much of medicine has gone down this route of being able to make algorithms and be able to make lines and say, well, everybody gets this, everybody gets that. And they keep telling us that AI is going to make this better and better and better. And I think it does for certain patient populations. Until it can figure out the intricacies of CHARGE, I don't think that there's any straight algorithm that's going to give us the answer that fits everyone. And so I think we pride ourselves on, while we do many of the similar concepts when you look across the different programs, we do really try to individualize the approach, because I think when it comes to secretion management, there is really no one surgery that fits all, despite the common misperceptions, despite the fact that many children get a lot of the same surgeries. At the end of the day, it's got to be really tailored to your individual child. So certainly there are lots of different surgeries out there we do surgeries that are aimed at the nose, we have the airway, swallowing, salivary, and of course, I'm sure almost all of you have heard one time or another about tonsils and adenoids. They kind of fit everything. And the tonsils and adenoids it's a very common procedure for children who have CHARGE, and it does actually solve a lot of the problems along the way. As you may or may not know, it can be a pretty rough surgery to get through, but it's also a pretty straightforward procedure. But the idea is that it does address some of the airway problems. It does address swallowing. It does address salivary management in the right children. So before I jump too far into other surgical procedures, I do want to touch on Botox. I think Botox has really revolutionized and changed a lot of the way we think about secretion management. And even though, like, at the end of the day, we really want to save anesthetics for when we really need them, surgeries for when we really need them. So when the medications just aren't cutting it, or there's too many side effects, and when therapy is just not getting us where we need to be, I think that's when we start going down thinking the surgical route. So Botox is sort of the intermediary between sort of big surgery versus being something intermediate. And the concept behind Botox, just like when it's being used for cosmetic reasons to make your eyebrows, make your face look younger, that sort of thing, it's the idea is that it actually paralyzes muscles. Interestingly enough, it just, as it turns out, it actually works very well on the muscles that squeeze saliva out of these salivary glands. And so if we take it back to the structure and to the anatomy we spoke about before, we know that the baseline secretions are primarily coming from the submandibular glands, but that we can also get the sort of the stimulated from the parotid glands. So what we do is we actually target those specific glands in general where we're trying to be able to control the secretions. You can actually mix it up a little bit on which glands you target based on the overall thickness of the child's secretions. But what we find is that it generally takes about 3 or 10 days for it to kick in, and generally lasts about 3 to 6 months. So very much like when you're using it for cosmetic reasons. Now that's kind of in a theoretic sort of basis. The reality is, and I imagine however many people are on here that have had Botox, which I'm quite sure is more than a few, there's a lot of different experiences. Some cases it works wonderful, and it actually lasts even longer than 6 months. Some cases it doesn't do anything. Some kids get a week or two. And it really is, it's kind of an interesting medication in terms of how you give it and then how you're able to control it. There are some children where we get a complete reset, where it just sort of buys the right amount of time and sort of sets them in to be a place where they're more manageable. But I also like to think of it in terms of sort of a process too, to understand. We say that in general, it's more of a swallowing sort of issue, that it's not too much saliva being produced, but the Botox does give us an option to be able to see what happens if we decrease the amount of saliva. So like any surgery, any procedure we do, we want to see the therapeutic sort of value. Does it work? Is it helpful? Because we want to do it to help take care of the kids. However, there's also some value too to like how well does it work? Because obviously nobody wants to be giving their kid an anesthetic every 3 months or so because the Botox is wearing out. And so if we find that it's working, it may lead us to something a little bit more aggressive for salivary surgery. Interestingly enough, there are times that if it doesn't work, it also may lead us towards a salivary surgery as well. But the important part is that it gives us good information to use along the way. And I think, and that's really what we want to like kind of keep in mind, is that while it's not the end all be all, it is a step and it's sort of a piece of the puzzle that can actually bring some clarity to what's going on with your individual child. Because it does get us to the rule of salivary surgery. And this is actually decreasing secretions. And if it's whether it's because of swallowing disorders, swallowing issues, whatever it may be, maybe an amount, maybe medications that they have to be on. But this is a kind of the same view that Kim was showing, except this poor child is just completely drowning in their secretions. And so as we mentioned, so as I mentioned, generally there are some different variations on the actual surgeries themselves. But usually what we do is we take out the submandibular glands, which are the ones that produce that baseline degree of surgery. Most of the time, I do have children spend the night when that happens, when they undergo this surgery, mostly just to keep an eye on things. And because, quite frankly, I just don't trust charged children to bounce back quickly from my anesthetics. And I expect them to do weird and strange things because that's just what your children do. And that's okay. Sometimes we'll do a little variation on that where we might tie off the parotid glands. Sometimes we'll do something called a salivary rerouting. That's pretty rare, but there are people that do it. There is always a possibility that while the submandibular glands can be excised completely, the parotids we cannot excise completely, and we just have to tie off the glands. And the reason why we don't excise them completely is the nerve that controls your face goes right through that gland, and we wouldn't want to put that at risk. And so these are very common surgeries, very commonly performed, and then various centers do different amounts, sort of volumes of it. But I'd say you take tonsillectomies, aerodectomies, you mix this in there. It's a very common approach to try to surgically manage the secretion problems. Nasal secretions, on the other hand, they can be controlled by various ways, whether it's removing the adenoids alone, sinus surgery, removing obstructions, working on kids. Sometimes after a corneal atresia, you can have a restenosis, which can increase the amount of secretions. But we also need to get back to the swallowing sort of piece to this. So whether your secretions are coming from your nose, coming from your mouth, coming from your lungs, if they're going down the wrong pipe and we are having aspiration, there's oftentimes things that we can do for that. And whether it's addressing what's called a laryngeal cleft, where we have secretions coming from behind, kind of in that picture that Kim had shown earlier, versus if children have a vocal fold that's paralyzed for one reason or another, whether it's from cardiac surgery, whatever it may be. Vascular rings can play into this. And occasionally we'll have some children who the upper part of their esophagus is just a little bit too tight. And oftentimes we'll even Botox there and sometimes make an incision just to help open it up. So all these things are to try to take the whatever volume of secretions and get the swallowing mechanism better and safer. And then when you take secretions themselves and sort of how do you manage it? How do you get them up out of the lungs? That's where airway surgery comes in. Sometimes you just can't manage it. We just can't get it through. And sometimes we place tracheostomies solely for the ability to be able to suction the secretions. Sometimes we do variations on opening up the top part of the airway. Sometimes we expand the airway. Vascular rings can be an issue. One of the other things that we run into, kids who have had tracheoesophageal fistulas, occasionally will have within their fistula, they'll have a remaining pouch that tends to create secretions. You can't remove those by coughing, and they just kind of fill in there. And so we've done various different procedures, both endoscopically and open, to remove these pouches, which kind of serve as like a cup that collects secretions. There are other roles too, such as things such as tracheopaxies, but it's all about sort of the plumbing it, opening it up. But it does get to the picture that it's much more than just having your tonsils, adenoids out, or just having drooling surgery. I do want to take one little plug. There's something that I personally am very interested, but it ties right into this. And this is something that we are really trying to understand. Children with what we call it the charged voice box, the charged larynx, there's a variation. This is a picture of a child who has significant redundant overgrowth. We should be able to look right down and see the vocal cords. And this is a child that you see the vocal cords hidden way down there. And this can really affect how you manage your secretions. And we're doing a lot of studying, a lot of data collection right now to really understand the spectrum of the different sort of presentations of the charged larynx. And I think it's really important it kind of fits into everything else with the chargers is that we have this wide variation. But I'd say one thing is pretty consistent. If you show me a laryngoscopy or a picture of a voice box, I can, I think, pretty accurately tell you that they have charge or not. And it's something that's not particularly well described, but something that we are working more towards. So that kind of gives a primer sort of overall the surgical piece. But I think the overall piece, one of the things I really wanted to make sure we did today was we had time to really take your questions because we're here for you. And while I know it's no surprise to anybody on this webinar that this is really difficult stuff, and any child with charge is their own unique variation on that, and that there's such a wide variation, but they're all special and they all have deserve the full sort of thought process. So with that, I think I saved us enough time for questions, and I think we'll go from there.
All right, that's wonderful. Great information. Thank you so much. We do have a couple of questions. We have one question from Soledad that she's asking, does electrostimulation therapy help with swallowing? And she's sharing that her daughter does not eat by mouth, only by G-tube.
We'll give that to Kim. It's controversial. How about that? Let's say, fire away, Kim.
I was unmuting myself. So it is like anything that we would use to target swallowing. It is one tool that some people and centers will use. It's controversial in the field in the sense of it's not an end all be all of you put electrical stimulation on and it's just going to improve function. Most of the research that's out there is more for functional based therapy, using all of the strategies and focusing on that from oral movement, frequency of swallowing, understanding the physiology behind that. And then after you're targeting that and understanding why can't we eat by mouth, right? There's lots of reasons, whether it's interest or movement of our mouth. Why would it be going the wrong way? The most common reason that we don't eat by mouth is because we're concerned of aspiration. But that in of itself is a big spectrum of why is that happening? Like I talked about before, it's not just if it goes the wrong way or not. What are our muscles doing? How do we understand that child and what can we do? Generally, there are things that we can do to help at least start somewhere. Once we know that and we have a therapy approach for all of the things you would do other than the electrical stimulation, then sometimes adding that onto those strategies can be helpful. There are reports of it being helpful, but it depends on what the muscle function is. It gets put on for specific kind of nerves. So I would say that the attention should be on all of the other strategies, and you're not just going for therapy to get electrical stimulation. When that's done, I would not expect it to be successful. It has to be done very frequently, minimum of 3 times a week, and with intensive therapy that focuses on specifically knowing what the muscles are doing. And so I hope that answers your question. It's really just not you just can't slap it on and then we're going to see improvement, but that in some patients can be appropriate, or some people find it appropriate to add on to everything else.
Mm-hmm. All right, thank you. We have a question. A parent is asking if the lack of oral element feeding could cause dystrophy.
So lack of oral feeding doesn't cause dystrophy, but lack of swallowing does. So you could not be eating by mouth and still be swallowing and handling your secretions. And so anytime we are not swallowing, we're not strengthening our muscles. And so the attention should be on secretion management and oral movement and improving the strength of all of that entire system to improve to keep muscle strength and prevent dystrophy.
All right, thank you. Now we have a question regarding Botox. Who will be a good candidate for it?
So I think a good candidate. So I think there's a couple different things that really go into deciding the candidacy. So first of all, sort of taking the whole picture of what has been done, what hasn't been done. So where are we with swallowing? Where are we with various other sort of procedures that may come? But really, when it comes down to it, Botox does serve the purpose of decreasing the salivary production. So I think from my standpoint, Botox comes in fairly early in our algorithm because we're trying to understand if we can, are these swallowing mechanisms able to overcome if we're able to decrease the volume? Now, one of the important things, though, that's really critical to think about, and for whoever's doing the Botox, is how thick are the secretions to begin with? And is the problem primarily drooling, or is the problem primarily choking and kind of in the area around the larynx itself, or is the problem that the tracheostomy secrete that they're suctioning from the tracheostomy? All those become important sort of nuance bits because what we want to be careful of is we also don't want to give Botox and run into a situation where the secretions become so thick that they're hard to manage. And so it's a quarter of a Botox is like a nice answer, but there's actually nuance that goes to it. And so I think when it comes down to it, is try to tease those little individual pieces, but the individual idea behind it is to decrease the volume.
And I would say I'll add on to that from timing of Botox, where if you're looking at reducing secretions, but the reason of why those secretions are not moving back and the swallow is not clearing them is not addressed, you could have Botox and that wears off and you still haven't changed function. So it's really important to understand how to improve that. What strategies help? Why are the secretions there? Why are they not moving back? How well can they be cleared? So that if you go and do Botox, so now your child starts to trust their swallow a little bit more, you optimize function in that setting before you're starting to have the secretions come back in more load. And that can be really helpful from a functional and airway clearance standpoint.
All right, thank you. We have a question from Riley. She says, my 2.5-year-old is constantly drooling. She has a cleft lip and palate, and they have been corrected, but she's also constantly chewing on her fingers. She understands some drool is present with normal teething, but she feels like with her mouth is constantly, she feels like she needs to be constantly stimulated. During her sedated ENT scopes, they said that no secretions in her airway and there's no irritation. Do you see that a lot?
Oh yes, we see that a lot, and I can only imagine as a parent how frustrating it must be to be told, "Oh, we don't see anything. It looks fine," but it's not fine. And yes, we do see that, and I think that and that's really, but it's also becomes part of that piece of the puzzle of understanding where the issue is. Clearly, the oral stimulation piece, I'll let Kim answer to that, but it's like obviously any oral stimulation is going to lead to increased amount of salivary production. And we know so many of these children do this stimming activity. And just because you see it up above, it may be that they're stimulating a significant amount of saliva, but maybe the swallowing is intact. And even though we kind of struggle with some of that, there are ways that's why it won't appear in the airway. And then what we always worry about is I think we've learned over the years, sometimes we walk out of there and it's like, oh, it's not my problem. It looked good on my side. And then the GI doctor didn't look good on my side. It's like,
Yes.
at the end of the day, it can't look good on everyone's side because we wouldn't be there if it looked good on everyone's side. Like there's got to be some sort of combination between the two. And that's where I think we as a team really try to make sure we hold ourselves accountable. So because nobody's going to put their kid under anesthesia unless they have a reason to do so. And so for us to come out and say it's normal, which may be a good thing. And it may be that there is nothing specific that's particularly concerning, but we still need to address the problem of the secretions and how they're affecting that child's life.
And what I think about is I say to myself, yay, that's great. The child is wanting to put things in their mouth. Think about jaw. We're moving our jaw. We're trying to chew on things. I like to focus on the things that are going really well. That's helping move some of the secretions back and some are going to come forward. One of the things that comes to my mind is from a coordination standpoint, we're focusing, and it's very common to focus on one thing at a time. I'm chewing. And as I'm chewing, I'm not going to focus on moving that saliva back. It's all going to come out. That doesn't mean he or he can't swallow. We're focusing on movement, which is great. It's helping jaw, it's helping our tongue, it's helping awareness. And it just might be strategies that are needed to know when to remove that, to teach okay, we chew a little bit and then it has to move back to swallow in focused periods, not all day, to realize when to more frequently move secretions back to swallow to have more swallowing frequency. And then understanding what's happening here. That's what determines whether you're going to see something in the airway. This is, we're not moving and swallowing frequently enough. How do we teach you to do that? And then what's happening once you move them back to clear it down to go the right way.
All right. We have a question, I guess, it's also it's coming from a professional. They say, Rebecca says, I'm seeing a patient who has a baseline secretions requiring nasal suctioning, and this has improved, and this is carrying over when taking PO requiring suctioning of nasal secretions mixed with liquids and solids. We had some improvement using cold carbonated liquids to increase sensory input of the PO to promote coordination and strengthening of the swallow with initially significant improvement prior to a prolonged plateau. Do you have any suggestions?
Well, I think there's a lot because it just depends on what that patient's swallowing profile is too.
I
think
think it's
Go
the
ahead.
one thing before you jump into it, I
Yeah.
think is understanding that swallowing profile. Because when I hear that as a surgeon, one of the things that I want to know is what is the integrity of the posterior, so the nasal cavity and the nasal pharynx. And so does the child have a cleft palate? Does the child have choanal atresia? Because those things become very important in terms of how like the overall swallowing profile and sort of from a structure and function sort of standpoint. And when you take those two pieces in, like there are some children who we're going to struggle from an anatomic basis. So regardless of how things work sort of down below, if you can't generate the pressure from above, you're going to run into these problems and you're going to run into this backflow sort of issue. And we struggle with this with the various different other specialties in terms of doing cleft palate repair specifically for swallowing can be a somewhat controversial, but we are believers in that, and we think that it does make a huge difference. So with that, I'll let Kim sort of talk about some of the individual sort of
Yeah,
thoughts.
very similar thoughts that I have. So you see secretions, you see food, liquid, but it all becomes why is that there? And just like Dr. Brigger was saying, it's an entire pressure system, as you know. And so we can help the response to the secretions there and the threshold to feel like you can swallow, but through suctioning and being able to realize, okay, I don't have anything in that area. I go to eat and I have a lower threshold where I will be able to swallow. But what the muscles are doing to be able to push it down so it doesn't go one way, plus it from an anatomy standpoint, just depends on the patient. And then what treatments you're doing depends on what that function is.
All right. We have a lot of good questions. We have one now regarding pulmonary management. Can you elaborate why charged kids need to take albuterol, atrovent, flovent, and what are the roles of each medication?
Good question. So first of all, the albuterol and atrovent fall in the family of bronchodilators, and flovent or fluticasone is anti-inflammatory. Often these medications are prescribed because you think of children with CHARGE who also get RSV bronchiolitis, metapneumobronchitis, different viral infections. And a cohort of these children can have a component of bronchoreversibility, especially when they get sicker. So that is one role of these medications. Second is that albuterol in some studies have shown to improve mucociliary clearance. That means it increases the beat of the cilia and that helps with mucus clearance. Atrovent in itself is an anticholinergic, and textbook doesn't say it, but it is more of an experience that it will help decrease the quantity of secretions, just like other anticholinergics like glycopyrrolate, scopolamine, and atropine does. But again, it is personalized. Some children show a big response, some don't. So this is why the medication list always needs to be revisited We need to de-escalate the medications if there is a consensus that these medications now can be as needed because the child is showing improvement in respiratory health. Fluticasone is an anti-inflammatory. There is no strong literature that it helps decrease the inflammation specifically in children with CHARD syndrome. But if a child with CHARD syndrome has, say, gotten influenza or RSV or metapneumovirus or rhinovirus, the literature is kind of pulled from other children who show wheezing associated with respiratory illnesses, and these medications kind of help keep the inflammation down, help these children deal with the next interaction with the viruses, hopefully a little differently. So, this is the role of medications. And specific to CHARDS, there are not many studies, but independent of the CHARD syndrome, there are studies that support the use of these medications.
All right, perfect. Thank you. Now, can a child who's high risk for aspiration and can't swallow enough barium for a good test ever hope to eat orally?
Yes. Yes. It all becomes why though. So, but that is the most frustrating thing for parents, I can imagine. And I do a lot of teaching with therapists, because it's usually what you hear, right? Is, okay, we need to know, are we safe? And the therapist, whether it's the community, or in a hospital, is, okay, well, we can only do it in therapy. We can only do little bits, so we know you're safe. But looking at it from like this pass fail, are you safe and you're going to go and pass your study? But it really can't be looked at like that. In order to get to the point of knowing what's going to help, we need to know function. And so that's where the scope sometimes can be helpful. Even if a child's not drinking a lot, we can understand where we put the scope in, we give a little bit of liquid, and we know what those muscles are doing. For a swallow study in radiology, I get a lot of information before the child has even taken any barium. I will sometimes put a little bit of barium in the cheek to get a reflexive swallow. Even if the child aspirates, I know that was probably my fault because it went a little quick, but I can see the muscles moving. I get all of the 20 some muscles that we're looking at that play off each other to know, this is what you're doing. This is where we can start in therapy. And even without barium, you see those structures move, and I can see the structures moving even without barium. And so it's a piece of information that gives insight to your child, not to determine whether they eat by mouth or not, but I understand that is often how it's used. So I hope that answers your question.
Yes, yes, that sounds very hopeful. Good news. We have a couple more questions. I have, if your child is missing a vocal cord, can they still eat orally without aspirating?
So I would say to that, potentially, and it totally depends on sort of what that looks like. I would say that I would be very hopeful that we could. I think that there are definitely ways and we have definitely procedures to manage that. Sort of, I'd say that the vocal cord itself, in general, it's rare for it to have to be completely missing. It's more, there's usually some remnant to it, or there is, whether there's been an injury or whatever it may be, there's lots of different reasons. But there are a lot of ways. So when I showed that sort of washer list of surgeries, I didn't even go into some of the off the wall stuff that we do. And we definitely do some off the wall sort of made up surgeries, which, because we take care of so many kids with these problems, we do have the opportunity to have some varying experiences. Bottom line is there are very few kids who I say just cannot eat. And so I would say our group as a team as a whole is very progressive in that. And so I would definitely would not lose hope on that one.
Good, good. All right. Next question. At what age do you begin doing medical-based interventions, medication, surgery, etc.? My son is 1 month old.
I would say it seems that the older we get, the younger we get, because things that we wouldn't do maybe a couple of years ago, as our experience has grown as a team, and we've been able to sort of push each other and had our families teach us, I think that we've learned to actually intervene at a fairly young age. I think we would be talking about it at a month or two old. Now, whether we would actually do it at that point, it's hard to say. But it is something that in the right child, the right therapy, the right sort of intervention, I think that I don't necessarily think of age as being a barrier.
Yeah. Yeah, but I think one thing I think we all have repeatedly said, it's a big team approach. And I think that would be, I think, critical when your baby is 1 month old, that you see us or you see a team that is practicing together and everybody's perspective is, kind of discussed, and then a very coordinated plan is made for the child.
Yeah, I can't stress that enough. I agree with you, Aparna. And I think the things that we do, and really that allow us to be able to push the envelope is because we do have the strength of our team together. And being that you are seeing roughly what, like 1/10 of our team, 1/8 of our team here right now, the
Yes.
three of us represent a small portion of our team. And all the decisions are sort of made together. And because of that, we do have, so I think if you take, in a different setting, like me by myself, I would be much more conservative because I don't have the sort of the power of the team to help me make the decisions. And I can only do surgical decisions based on having the team be able to work with us closely. So I think that point's very well taken, Dr. Rao.
Awesome. Let's see. We have so many still. Let's see. Have you seen a direct correlation between a child's inability to manage their secretions or aspiration and an acute onset of a diminished respiratory drive? Emphasis on the child losing their respiratory drive for a prolonged period of time.
I mean, so I think it depends upon the respiratory drive. Is it related to the start of medications? Is it related to, some other trigger? Because usually children with charge have good respiratory drives. It's just that their swallow function which is, different. And with respiratory illnesses, yes, it can be a big challenge initially, but with the right therapies and the right management, most children can recover from a breathing perspective. The central drive, that is the brain, when it is suppressed, is usually related to medications. It is not related to charge syndrome.
But I will say that the charge syndrome, like phenotype, that the variations in charge syndrome and the
Yes.
way their wiring goes to the brain we barely understand it for quote unquote the normal kids, right? And I think
Yeah.
in charge kids, we spend an awful lot of time trying to project what's supposed to be onto children with charge. And I'm quite sure all of us on this call know that that just doesn't work. And so
Yeah.
we need to be able to think bigger and outside the box and be able to accept what the parents say and be able to
Yeah,
accept that feedback
absolutely.
and
Yeah.
realize that it's like, my books might say that you shouldn't be experiencing what you're experiencing, but I know you're experiencing what you're experiencing.
Yeah.
And so somehow we have to reconcile that.
Yeah. And I wondered, I would like to know from the parent, did they get a sleep study done or anything else to kind of define what the respiratory mechanics were like? That would also be very helpful, because if there has been a trigger for it and that has changed the breathing mechanics, it's best picked on a sleep study or on an assessment of the mechanics of breathing.
All right, so we have time for one more question. I'm sorry, we still have a few. If
Sure.
you notice that your child has more problems managing secretions while sleeping in supine, would you recommend another sleeping position that allows for better clearance of coughing the secretions and getting them out? And this is for a 1-month-old.
That's a loaded question right there, whether you know you're asking a loaded question or not. And so the hard part with a 1-month-old is sort of what the national recommendations are in terms of how they should sleep. And so the back to sleep sort of piece to this. Is it possible that different positioning? Absolutely, it is absolutely possible. But I think the other question that really needs to be answered in that is it truly a secretion volume sort of problem? Is it truly a secretion management problem? Or is there an anatomic issue? And I think that's a really, really important piece to pull out of this. Because a 1-month-old, when they're struggling, things that sound like secretions oftentimes can be laryngomalacia. They can be tongue-based collapse. There are a number of different entities that can be masquerading as secretions, because that's what you hear. But what it is how the secretion is sort of bouncing around. And so that's where, so it's like hard to know. And we're very careful, I'd say, about ever recommending different sleeping positions, particularly in a 1-month-old, because of sort of the known implications that go along with that. Once again, sort of translating some of this data for every child, but also, but by the same token, we don't want to put kids in danger. And so I think it's really important to understand what you're treating and how you're treating it and why you're treating it.
All
Yeah.
right, perfect. And let's do one last question. This parent is asking, where do we start? Who do we see? And what type of assessment and exams we should be asking for to understand how to treat my 2-year-old secretions? So far, we have noticed that lansoprazole used for his reflux helps him produce less secretions. Currently, we manage his secretions with Pulmicort and albuterol nebulizers, chest PT, and the use of a suction machine.
So I think that's a great question. And I think it's something that we as a institution, we as a program, we as a center, whatever, like all the various different circles that we are asking all the time. And a lot of it has to do with sort of where you are, what you have access to, because as we all know, like the ability to be able to access care is different across the country and across the world. And sure, like for what do we think? We think you should come see all of us. You're gonna, you're gonna be all day long, and we're gonna come with all these different things, and you're gonna get this complete evaluation that has the constant sort of conversation going back and forth. Now we know like that's not a common thing. Like that's just like we're very lucky to have that, and really we have that because families of children with charge syndrome have really supported us and really helped us to build that. But it's hard to be able to build such a team. And I think, and that's what the most important part when you're starting out with the initial evaluations is to have various team members. I think at a minimum, you need to have a pulmonologist, an otolaryngologist, and a speech pathologist, as evidenced by who we have here today. I think that's sort of the bare minimum, and they need to be talking to each other. I think that's how, in order to make it, it's like they have to have some sort of working relationship where they can communicate because this stuff's way too hard to do in isolation. And I think, and that's where our bias is obviously to have a big, large team with everybody there. But I think at a minimum, you need to have the different people who have been some degree of training and be able to manage this type stuff, but all talk to each other.
Yeah, teamwork is definitely key with Charge syndrome when there's so many things that you have to look at. We had several questions actually of where do we get in touch with you? Do you do consultations, second opinions? For everybody on the webinar, I just put on the chat box their website that lists how to contact them and how to begin this process, but I'll let you guys answer it.
Yeah, I think the website says it all.
Yeah.
We love to chat about this stuff. We always love to discuss. We are actually in the process right now. We have a little turnover, and so we have a couple different people who do the coordination. I think Karen's on here. I think I saw that she's on there. Karen is the main go-to right now. We have a new APP that we're going to be joining us here. We're working on some of the final specifics of, which will be great. And I think, Karen knows how to get us all connected. And as you go through that website, it's gonna get you to her.
All right, perfect. And it's good that you all know that that you guys are there, that we have a charge center in California. And if for any of the parents that are wondering, how am I going to be able to travel and do that, this is something that Karen or their coordinator helps you figuring out the all of the details regarding insurance. And our foundation also has a medical travel program that helps support families that are having to do travel to get second opinions or see teams like yourself. So,
And I think an important part that I think I saw in one of the questions here is we do work directly with your referrer. Like we like to do an evaluation. We kind of come through, we some the overall recommendations, but we spend an awful lot of time talking to your local treating therapist. We know you can't come see Kim every week. Like we know that's not going to happen, right? But we do know it's like that there's a way for us to be able to communicate in a way back and forth. And so we do that with the team on the ground. And so we'll form the relationship with your team as well.
Awesome. That's perfect. We're getting a lot of love in our chat box. Parents are really grateful and happy for the information. And we definitely thank you for your time, for joining us. And hopefully, everyone's going to join us next month at the next webinar. We're going to talk about the ways that we play. We're going to have a couple of physical therapists from Perkins sharing things that you could do for fun during summer. So, thank you everybody for joining us. Thank you for the Rady's team. It was wonderful to have you. And we hope you all have a wonderful night.